Good afternoon, everyone, and welcome to the Smart Policing Initiative webinar. I'm going to kick things over to our project director, Dr. Chip Coldren, to start us off this afternoon.
Very well. Thank you, Zoe. Good day, everyone. My name is Chip Coldren. I'm the Managing Director for Justice Programs at the CNA Institute for Public Research and the Director of Technical Assistance for the Bureau of Justice Assistance's Smart Policing Initiative. I will provide the introduction for today's webinar on community responses to people in crisis. I am particularly proud of today's webinar on responding to people in crisis because the webinar title directs us to community responses in these situations, not just law enforcement responses. This, I believe, is strong evidence of the recognition in our respective fields that first, the police and the community are one and the same, and second, we recognize that the response to people in crisis, particularly those in crisis who find themselves confronting the justice system, must be a collaborative, community-wide response, not simply a police response to a call for service. This, I believe, represents advancement in a collaborative approach to policing and in joint police-community responses and shared responsibility for problem solving. We are pleased that several of the BJA law enforcement mental health learning sites will join us in this webinar. So I'd like to say a few words about this initiative. In an effort to expand the knowledge base for law enforcement agencies interested in starting or enhancing a specialized police response, the Council of State Governments Justice Center, with assistance from a team of national experts and BJA, selected 6 police departments to act as national law enforcement mental health learning sites. Located across the country, these learning sites represent a cross-section of perspectives and program examples and are dedicated to helping other jurisdictions improve their responses to people with mental illnesses. Selected were the Houston, Texas Police Department, the Los Angeles Police Department, the Madison, Wisconsin Police Department, the Portland, Maine Police Department, the Salt Lake City, Utah Police Department, and the University of Florida Police Department. So as I said, I'm proud to present this webinar on behalf of the Bureau of Justice Assistance, and I'm proud of its message and its content. Several of our colleagues will present information to us today. Dr. Laura Kunard, Senior Scientist in the Justice Group at CNA and a Smart Policing subject matter expert, Sergeant Kelly Bush, Corporal Thomas Kelley, and Corporal Kannika Nimithkoune of the Pinellas County, Florida Sheriff's Department, Brandee Casias from the Salt Lake City Police Department, and Lieutenants Brian Bixler and Charles Dempsey from the Los Angeles Police Department. Dr. Kunard is the former director of the Center for Public Safety and Justice at the University of Illinois, a regional community policing institute of the Office of Community-Oriented Policing Services. She recently completed the development and pilot testing of an updated crisis intervention training curriculum for BJA. Her presentation today will cover different approaches that have arisen regarding how to respond in a comprehensive and collaborative manner to people in crisis. Sergeant Bush and Corporals Kelley and Nimithkoune from Pinellas County represent one of 3 smart policing sites that recently received grant awards from BJA to implement innovative approaches to responding to individuals in crisis. We note that Roanoke County, Virginia and Shoreline, Washington also received smart policing grants from BJA for their innovative efforts in this area. They will discuss the High Utilizer program developed by the Mental Health Unit in the Pinellas County Sheriff's Department. Lieutenants Bixler and Dempsey from the Los Angeles Police Department, which serves as a BJA National Law Enforcement Mental Health Learning Site, will discuss the 5 pillars of the Los Angeles Police Department's law enforcement and mental health response strategy. Brandee Casias will describe the Salt Lake City Police Department's Mental Health and Substance Abuse Unit. This department also serves as a BJA National Law Enforcement Mental Health Learning Site. As many of you know, this is one of a series of webinars sponsored by the Bureau of Justice Assistance and coordinated by CNA, the technical assistance and training provider for the Smart Policing Initiative. We thank the Bureau of Justice Assistance for its long-standing support of the Smart Policing Initiative. And as I like to say, they don't just support smart policing, they champion it. We thank our presenters, as well as Kate McNamee and Maria Fryer from BJA, and our mental health technical assistance partners from the Council of State Governments for the efforts they made in putting this webinar together. And we also thank our participants who have joined us today. Permit me a few other comments, and then we'll get started. This webinar is recorded for the benefit of others who may view it later on our website. So please be mindful of that as you make your comments. There will be opportunities for questions and participation during the webinar, so please make your thoughts and questions known. I can assure you that others will appreciate hearing what you have to say. Immediately following this webinar, you will receive a request to evaluate it. Please complete the evaluation and please give us your honest thoughts and recommendations, especially regarding other webinars you think would be helpful. Now let me also thank Vivian Elliott, Zoe Thorkelson, and Kamia Raja at CNA who do the background work to make sure these webinars go smoothly. Zoe will cover a few logistics and then turn the webinar over to Dr. Kunard. Okay, Zoe.
Thank you, Chip. I'm just going to go into a little more detail about the question and answer sessions for everybody. During those portions of the presentation, if you'd like to ask a question, you can send it to me at the Smart Policing Initiative host account through the chat feature, and I can read your question aloud if you'd like. The other option is that if you'd like to ask the question yourself, you can certainly unmute your phone and ask during those sessions. We do ask, however, that if you are not currently speaking, that you keep your phone line muted to reduce background noise during the webinar. Also, if you have any technical difficulties or need any assistance, please feel free to chat to me at the Smart Policing Initiative host account, and I will do my best to help you out with solving those problems. Thank you again for joining us, and Dr. Kunard, I'm going to turn it over to you.
Thank you, Zoe. Good afternoon, everyone. In this overview session, we will focus mostly on definitions of common models of police mental health collaboration, including crisis intervention teams, CoResponder models, mobile crisis teams, case management teams, and other tailored approaches. That will be followed by the case studies from the agencies that Chip introduced just a minute ago. I'd like to begin with a quick note on terminology because I believe that language matters. People with mental illness will be referred to as such throughout this presentation. I choose this people-first approach because I believe it reflects the priorities of police mental health collaborations. Other terms that refer to people with mental illness, including clients, consumers of mental health services, and peers, may be acceptable to some, but they may not be acceptable to all or acceptable in all contexts. I encourage everyone to make efforts to educate yourselves about your community's local and lived perspectives on terminology. Next, I'd like to draw your attention to the recently launched BJA Police Mental Health Online Toolkit. The website address is there on the slide for you. This website is an amazing collection of resources, including videos and curricula, and it contains planning guidance about police mental health collaborations. The idea of the toolkit is to assist agencies who do not have an active PMHC or wish to learn more and find an existing program in finding examples and tools to assist them. I encourage all of you to explore it soon. And just one note for those of you who are participating on this call, if you could all stay on communities, fewer uses of force by officers, fewer injuries to officers and community members, jail diversion, really effectively connecting people with mental illness to services, reducing repeated calls for service to the same address or involving the same people, and minimizing the strain on agency resources. The first and most common approach of a police mental health collaboration is the Crisis Intervention Team approach, also known as CIT. And it's appropriate here to take just a few moments to acknowledge how we arrived at this moment in law enforcement and a little bit of background about CIT. CIT grew out of an incident in Memphis in 1987, which was an officer-involved shooting of a person with mental illness. The mayor of Memphis turned to the National Alliance on Mental Illness, or NAMI, for assistance. Together, NAMI, the Memphis Police Department, and university leaders at the University of Memphis, in partnership with the city and mental health professionals and community leaders throughout the city, developed the CIT model. Since 1987, CIT has been steadily adopted by law enforcement agencies throughout the country and the world. CIT officers rely upon their expertise to work with mental health providers to reach an appropriate disposition. Note that the T in CIT stands for team and not training. It's important to remember that the CIT model is more than just a training model. Next are co-responder teams. Working as a co-responder team, a specially trained officer and a mental health crisis worker respond together to mental health calls for service. By drawing upon the combined experience of the officer and the mental health professional, the team links people with mental illness to appropriate services or provides other effective and efficient responses. The most common type of this model is for the officer and a crisis worker to ride together in the same vehicle for an entire shift, while other agencies, the crisis worker meets officers at scenes of calls for service, and they handle the call together. Co-responder teams can respond throughout entire jurisdictions, or they can work geographically in an area that has the greatest number of mental health calls. Next, we want to review mobile crisis team concept. Mobile crisis team is a group of mental health professionals who are available to respond to calls for service at the request of law enforcement officers. The mobile crisis team's goal is to divert individuals from unnecessary jail bookings and or emergency room visits. These crisis workers are skilled at helping to stabilize encounters and assume responsibility for securing mental health services for people in crisis, including those who may need further evaluation and treatment. Mobile crisis teams are not necessarily dedicated to assist only law enforcement officers, but often respond to requests directly from community members and their families and friends. Case management teams are proactive teams in which behavioral health professionals and officers provide outreach and follow-up to repeat callers and high utilizers of emergency services. Officers, of course, do not treat or diagnose the individuals, but work hand-in-hand with behavioral health professionals to develop specific solutions and reduce repeat interactions. This approach strives to keep people connected to the mental health care that they need, the community resources, to assist them in abiding by treatment plans and meet other responsibilities such as work, school, training, and family and child care. Case management is often used in agencies in conjunction with other police mental health collaboration strategies. And finally, there are other tailored approaches. So this is really an approach in which an agency intentionally selects various response items and options from everything that I've reviewed so far to build a comprehensive and robust program that fits their community. This allows the agency to adhere to a consistent policing philosophy while being responsive to community needs. Other factors that agencies usually consider when customizing their approach include the size of the jurisdiction, the number of officers on a given shift, and of course, community resources available. So when using a tailored approach, law enforcement agencies and their communities are often quite creative and coordinate with various stakeholders within the criminal justice system and the mental health community. Now I'd like to turn the webinar over to Corporal Kelley and Sergeant Bush so that we can have some examples of police mental health collaboration.
Hi.
Corporal Kelley?
Yes, stand by. Our site just clicked off that our event no longer is active, so I'm trying to get connected back on. Are you able to forward through as we go?
Yes, Zoe, can you help out with that?
I'm trying to log back in. I literally just clicked over.
Okay. Good afternoon, everyone. I'm Kannika Nimithkoune. I'm a corporal with Pinellas County Sheriff's Office, our mental health unit. With me, I have Sergeant Kelly Bush and Corporal Thomas Kelley. On behalf of Sheriff Bob Goldterry, we'd like to thank you for letting us participate in this webinar. Today, we're going to go over our outline, which will talk about our county's population, our high utilizer program, our Baker Act and Marchman Act, and also the Sheriff's Office implementation of the mental health unit. And it will also go over some of our anticipated results and outcomes of each program. Right now, Pinellas County sits on the west coast of Florida, directly across from Tampa. It's the second smallest county in Florida, but it's also the 6th largest in population out of 67 counties here. Right now, the population is listed as 949,827 in 2015, but that also includes 6 million visitors annually. Pinellas has about 24 municipalities, and right now the Sheriff's Office contracts with 13 cities and provides law enforcement services to about 41% of our population. As of right now, I'm assigned to the county's high utilizer program, so I spend about 20 weeks assisting with the program. I do about 20 hours a week, assisting with the program with law enforcement functions. I help them locate clients, I make contact with the clients, I also do follow-up. The target population for the pilot high utilizer program is a pre-identified subset of 33 target individuals who are frequent users of the county's public Baker Act facility and the county jail. These individuals are frequently homeless and also often have co-occurring behavioral health and medical conditions. They're also frequently involved with the criminal justice system. It's estimated that these 33 individuals were costing our taxpayers about $2.5 million annually. So with this pilot program, we determined that it would cost about $946,000, and that's to provide things like wraparound services to these individuals, and it's about 62% as far as reduction in cost. Some of the goals with the high utilizer program is to provide housing first. A majority of these individuals that we identified in this work group are all homeless. So the pilot model requires that housing first approach. This evidence-based practice centers on providing stable housing for these individuals. And then along with the stable housing, they'll provide other services as needed. To us, housing is more of an important tool than a reward for compliance or recovery. Approach to ending homelessness incorporates engagement, housing, intensive treatment, other social services, and that's to stabilize the individual so that they can live independently in the community. And that's for either permanent or supported housing so they don't have to leave. We also provide basic necessities like clean clothes and food, medication treatment, long-lasting injections, and as well as client engagement and therapy. With the Sheriff's Office, we collaborate with the community partners. So the pilot team obtains their services based on identified need, including financial assistance, employment assistance, getting them benefits, ongoing medical and behavioral health care, and things like sufficiency assistance like life skills, hygiene, food prep, budgeting. We also provide transportation, family and social relations, family reunifications. We've also done legal assistance. They provide parenting skills. They give them access to financial benefits like Medicaid, Medicare, SSI, food stamps, the county's Adult Emergency Financial Assistance Program, and also the Pinellas County Health Program provides the opportunity for them to maintain self-sufficiency and to remain engaged in meaningful and productive activities such as school, day services, employment, or even volunteer work. So some of the things that we'll do is we'll engage these clients out in the street, in the hospital, or in the mental health facility, using the housing first approach, obviously, and then following up with wraparound services. As of this date, we have about 24 clients enrolled in the program, and some of the anticipated results for our program are as follows. For short-term goals, we represented that we're trying to figure out if there's an increase or decrease in clients enrolled in the program, homeless house within 1 week of entry, assessment within 1 week of entry, see if the clients are receiving mental health treatment, and also if they're receiving wraparound services. Some of our long-term results are to see if number and percentages of clients who successfully complete the treatment plan, if there's an increase or decrease of clients in permanent or not permanent supportive housing longer than 6 months, if there's a reduction if the clients are being arrested 6 months post-entry, as well as a reduction with clients with Baker Act 6 months post-entry. Also clients in detox 6 months post-entry, hospitalized, and to see if there's an increase or decrease of community self-sufficient services. We also want to see if these clients are able to get into paid positions and also engage in meaningful and productive activity. So that's just a brief overview of our county's high utilizer program. Corporal Kelley is now going to talk about the Florida Mental Health Act.
Hi, good afternoon. I know we're having some technical difficulties, but it seems like we're caught back up now. So good afternoon. I'll go over the Florida Mental Health Act, otherwise known as the Baker Act. Also, I will cover our agency's new mental health unit. Our Baker Act is a proceeding which means we're providing an individual with emergency services and temporary detention for mental health evaluation and treatment. Either this is a voluntary or an involuntary basis through a law enforcement officer or professional treatment through a mental health facility. In 2015, Pinellas County had 11,234 Baker Acts. Of that, 2,841 were done by the Sheriff's Office here. 382 individuals were Baker Acted more than once, and 12 were actually Baker Acted more than 5 times. Of the involuntary Baker Act, almost 2% were ex partes from the courts, 50% were LEO initiated, and 47% were from a professional certificate. These individuals are held in a receiving facility for no longer than 72 hours unless otherwise deemed necessary due to mental health concerns. This 72-hour hold provides crisis stabilization and review by a mental health doctor. Referrals may be provided upon release along with medication and scripts. There is no additional follow-up by law enforcement once they are dropped off at this receiving facility. Around the middle of the year, the Sheriff's Office was awarded a BJA grant to hire 2 mental health navigators to help assist with our involvement with the mentally ill. Our sheriff asked us to create a mental health unit and provided 5 sworn personnel to man this unit. The unit is comprised of 1 sergeant, 2 corporals, and 2 deputies. Once the mental health navigators are contracted, they will be teamed up with the 2 sworn deputies and they'll assume a co-responder team approach. The team's primary duties will be to assist subjects with mental illness by responding to in-progress mental health calls. Also, they'll conduct follow-ups, refer services, and they'll also be reviewing police reports involving mental illness. The grant also provided a research partner, which is housed here at the University of South Florida in Tampa. They'll be collecting data and providing quarterly and biannual reports to measure our outcomes. The researchers will be looking at demographics, arrests, jail admissions, court dockets, benefit enrollments, cost and taxpayer dollars, and Baker Acts. The Sheriff's Office hopes to show successful outcomes in the following categories with the involvement of the new mental health unit: arrest-free for 6 months, Baker Act-free for 6 months, Marchman Act-free for 6 months, and with our Marchman Act, this is the involuntary or the voluntary assessment and stabilization of a person allegedly abusing substances like drugs or alcohol, and provides for treatment of substance abuse. These individuals are taken to our county jail or a hospital. And also we want enrollment in a mental health program to help stabilize the client is one of our goals. This concludes the Pinellas County Sheriff's Office portion of the webinar. We'd like to turn it over to the next presenter. Any questions?
Thank you so much, Tom. Any questions? Feel free to drop something into your chat box, those of you on the phone. And if not, we will... I'm sorry, go ahead.
There's a question from the chat. Someone is asking, can you tell us what types of costs were used to determine the $2.5 million annual cost for high-frequency users?
They based it off on the Miami-Dade high utilizer. What they did was they took a formula and calculated how many individuals were in crisis stabilization units and how many days and how much that cost, along with how many days they spent in the jail versus multiplied that by how much it costs each day to house each client. And so that's what they came up with those numbers. And they said that with doing this type of wraparound service, it's almost like a SAC team approach. And by doing that, they were going to have a big reduction in costs.
Okay, great. Thank you.
Thank you.
Thanks. Zoe, any other questions?
No other questions for the presenters.
Okay, great. So let's move along to Lieutenant Bixler and Detective Dempsey.
Excellent. Thank you so much. I'm Lieutenant Brian Bixler of the Crisis Response Support Section. Along with me is Detective Charles Dempsey, who is the detective in charge of our administration and training unit here in the mental evaluation unit. On behalf of Chief Charlie Beck and the Los Angeles Police Department, thank you so much for allowing us to be a part of this and to share a program we're pretty proud of and that is expanding and changing almost on a monthly basis. I'm going to cover real quickly just kind of how our program is designed. And then we'll open it up for questions after that. As I said before, I'm a part of the Crisis Response Support Section, which includes our mental evaluation unit as well as our threat management unit. And our threat management unit handles most of our Hollywood celebrity stalking cases, as well as threats against elected city officials and city employees as well. Moving on to the next slide. We're going to talk about our program is based on 5 pillars of our effective law enforcement and mental health response program. First one is going to be training, followed by triage, then crisis response, follow-up, and community engagement. And I'll go into each one of those as to what they are and how we work through them. The first one is training. We are one of those agencies, and I know there's a national discussion on, do you put everybody through a 40-hour course, do you not? We have come to the conclusion that in Los Angeles we are going to put everybody through that course. The first part of that you'll see is police science leadership. That's actually a new program we implemented where when recruits graduate from the academy and they have 11 months out in the field, they will come back for 2 weeks. The first week involves community policing and other issues. That second week, they're actually going to come through our mental health intervention training 40-hour course. So that way we catch them after they've gotten some field experience, they understand the scope of the problem, and they can apply what they've experienced over the last 11 months into the class, and it becomes a real dynamic environment. We also capture our field training officers. There is a legislation in the state of California that mandates that all field training officers receive 8 hours of mental health crisis training, and we're trying to put all of our field training officers through that 40-hour school as well. We run that school every 2 weeks. We hold it at about 30 to 35 students per class to make sure that learning environment really works well, and part of that is because we kind of hold the philosophy, and Charles Dempsey came up with this, it's not what you teach, it's how you teach. And we can sit there and lecture, teach them lots of things, but until it really becomes part of who they are and changes the attitudes, that's what we're really looking at. And as a matter of fact, we're having a couple of our clinicians do a study right now measuring police attitudes coming into the class and when they leave, and to see if there's a change in that. So we're real excited about that program. We teach that in conjunction with NAMI, the Autism Society of Los Angeles, as well as the Los Angeles County Department of Mental Health, without whom we couldn't do what we do. Yeah, we can move on to the next one. So that's where it all starts, because when we look at how we're going to respond out there, this is a very large city with about 2.5 million calls for service a year. We know that as a co-response model, we're not going to get to every call in a timely manner, especially over the geographic area we have to cover. So we know that patrol officers are going to respond first. That's why we want them to have that training, because they're going to be the ones to respond first and foremost. We've built into our policy and procedure at triage. We have a 24-hour, 7-day-a-week triage desk that is manned by specially trained officers who will take field calls from patrol officers. Our patrol officers are mandated by our policy that whenever they run into somebody who is a person suffering from mental illness, they are mandated to call us at the triage desk and report to us what's going on. At that point, our officers can figure out what to do from there, and that's why we call it the triage. That first mandated reporting piece, we capture every piece of data we can. We track every call. We look at outcomes. We look at why the call was generated in the first place. And hopefully that will give us historical information. And when we go out later, we'll have background of what worked, what didn't work, and how to move on from there. Our officers give advice and guidance to the police officers out in the field. If possible, and we have that unit available at the time, we will dispatch a SMART unit, and I'll go into what that SMART unit looks like in the next couple slides. We can also, if a smart unit is not available, we can determine the best location for treatment for this person, whether it's a county hospital, whether it's an urgent care center, which has really changed the way we do business out here, and diversion from custody. We actually built in diversion into our policy as a police department, where we give the watch commander of our 21 geographic divisions the authority and the ability to divert somebody from custody into a mental health treatment facility. We build that in by saying if they see that this case is maybe a low-level misdemeanor, not a crime against person, and this person is eligible to be diverted to mental health, they can do that. We do, however, make sure that we look at victims' rights as well, because if there is a crime involved, we want to take the rights of that victim into consideration as well. Let's see, where am I? Okay, we're talking the next the next pillar is our response, our crisis response. We have 17 CoResponder models that go out every day on a 24/7 basis. That CoResponder model includes a police officer, specially trained, as well as a Los Angeles County Department of Mental Health clinician. Both officer and clinicians were selected for their ability to handle this job, to work together, which is always unique. And we know we're doing a good job when you have a police officer talking like a clinician, and you have a clinician talking like a police officer, which does include some foul language every once in a while. But that's when we know we're doing a really good job at mixing the two and having a good team concept. They will respond at the request of patrol officers and at the direction of our triage desk, and they will do an in-field clinical assessment. They preferably, we would like to meet a person where they were located, if that's in a caregiving environment in their home. If not, we'll have officers meet them at the station, and they can do an assessment there. Our county clinicians determine insurability and really look for that linkage. We'll go to great lengths to find the appropriate facility and the appropriate linkage for that person, even if it means driving a great distance out of the county. We do it all the time because we want to find the right place so that we don't have that recidivist behavior that occurs so often when we have officers who say, look, I put this person on a hold yesterday, I see them on the same street corner today, and that can be really frustrating to both officers and the community as a whole. Moving through, we don't stop there. We have in our system, when we pulled up our triage desk, if there's certain criteria met, they're a high recidivist, they're a person that is escalating behavior, there's directed threats to school violence, there's lots of critical things we do, and we're actually adding in somebody who may be looking at violent extremism. We're going to actually just have a checkbox in our triage report that allows it to be forwarded to our camp unit, and that's our follow-up unit. It's the Case Assessment Management Program. And in that you have 7 teams of a detective, an LAPD detective, paired with a mental health clinician. And they will get these cases, and I'll go over some of the numbers. Their caseload is quite high, but they're looking at making sure that this person does not repeat the behavior. We're looking at really reducing risk by taking guns away, by taking weapons away, by going to the home to try and come up with a safety plan. And it's become a very, very effective model. I know it's just one of many, but it's really been a good thing for us. Sometimes it can take up to a year to really effectively work through somebody's issues, to get them linked to the appropriate services, to make sure that family has the resources they need. And again, we're looking at prevention, risk reduction, and that linkage, long-term linkage for that person as well. The last piece is what we call community engagement. We think that, like all the other programs we've talked about, linking up with community resources is key. And we're finding as we look through, there are so many little resources that you may not know about. For example, we had a mental health crisis response program advisory board, which is a quarterly meeting we have all throughout the city. We take it at different locations. At one of the more recent ones we had, we opened it up to the community, to providers. We had a provider in there who specifically catered to the transgender community. We didn't even know this clinic existed, but they showed up there, showed us their resources, and that became a really vital part of making sure that the officers in that area knew what resources were there. Again, we couldn't do this without the Los Angeles County Department of Mental Health. NAMI is involved with us. ASLA, or the Autism Society of Los Angeles, is greatly involved in that, and community service providers. one of the things that we did with NAMI is we started, when we had these discussions in our class, we realized there was some misunderstandings from family members to police officers. You know, NAMI folks would ask, why do you separate us when you come into the house? Why do you handcuff? Why? And police officers in the same way would say, why do when we come in, we can't tell who's the person suffering from a mental health crisis, because everybody's in a crisis at that point, which led to some really good discussion. And what we decided to do is, in conjunction with NAMI, is to come up with a 911 checklist to hand out to family members at community events. We give them this thing and say, look, if you ever need to call 911, we hope you don't, but if you do, look at this list. This is going to give you the information we're going to need when you call 911 and what to expect when police officers show up. This has been a huge tool in gaining trust from the community and gaining the cooperation of the community. We've also implemented a new program called the Mental Evaluation Unit Senior Lead Program. As a Los Angeles Police Department, we have senior lead officers assigned to our patrol beats. There was one officer assigned to a patrol beat to handle community-related problems. Well, we decided we needed officers that are just going to focus on mental health issues, link officers to mental health services in the community, and link up families to those services as well, and act as a liaison between that. So I was able to hire 4 officers. They're assigned to the geographic bureaus. We have 4 geographic bureaus in the Los Angeles Police Department. Although they're quite large, they've done an amazing job at getting out there, finding what the problems, what the gaps are in linkage between the community, the families, and the police. And that program is still developing, but it's become a vital part of our program to reach out and find what resources are out there and how we can link people up to them. They also do board and care facility investigations and really whatever is needed by the patrol areas in conjunction with our Los Angeles County Department of Mental Health folks. We also are part of the system leadership team, or the county SLT, which is a kind of oversight, decides how the money coming down from the state is going to be spent. So that really helps. We're also very actively involved in our citizen police academies to make sure that there's good flow of information going back and forth from us to the community. Just looking at kind of some of our numbers, we use CompStat as kind of how we're graded by our department. And looking back just at some of our calls, in 2015, we count crisis calls. We don't count when somebody says, hey, there's somebody who we believe may have be mentally ill. We get there, there's nobody there. We don't count those calls. We don't count the ones where it comes down to just somebody sleeping on a corner or whatever. We actually count confirmed mental illness calls. And there were 16,504 of those calls. 80% of those, believe it or not, were in a caregiving environment, whether it's a residence, a board and care facility. That's a shock to a lot of people, and only 20% were homeless. And, a lot of that is because there's underreporting in the homeless community. What becomes acceptable on Skid Row is definitely not acceptable on the west side in Los Angeles. 78% of those calls resulted in involuntary mental health detention, which is under the 5150 of the Welfare and Institutions Code. 60% resulted in a one-time contact due to successful initial intervention. That's when we know we're having good outcomes, is that only 60% of them are just one time, and they get effectively linked to an intervention strategy. 10% resulted in arrest. 350 individuals were diverted from custody pre-booking. That means the watch commander said, no, we're not booking this person. We're going to put them right into mental health treatment by using our SMART teams. And 16 individuals were diverted post-booking, which means that they got into jail, and somewhere along the way we were able to divert them away from the criminal justice system. Going on, and as you can see down there, 716 cases were referred to our CAMP unit, which is our detective follow-up unit, so that's a very large caseload for only 7 teams to handle. We also handle all firearms seized under 8102, which is our Welfare Institutions Code that allows us to take any weapon from a person who is going to be evaluated for a mental health hold. And we track all of those as well. Now, if you were interested in getting more information, we're going to actually show you a quick video of one of our we're not going to show the video, but you can go to that video as part of the toolkit put out by BJA, and has some really good information on kind of collecting data, how to collect data, and why. That brings us to the end of our presentation. If you want anything from us, there's our social media, as well as you can contact us through BJA, and we'll be more than happy to share any of our information, including the 911 checklist or any policy issues you want to have. So with that, I will go ahead and conclude and see if there's any questions.
Thank you very much, Detective. Zoe, did any questions come in on our chat box for Detective Dempsey and LAPD?
I haven't received any questions, but we did have one question that was submitted prior to the webinar that I could put forth. So this person asked about what about other first responders, communications personnel, dispatch personnel, and other sorts of secondary impacts that can occur due to interactions with persons with mental health issues.
I'm sorry, could you repeat the first part of the question?
Yeah, they were asking about basically how your program or your department has handled the secondary impacts that may sort of ripple out from the police officers to other first responders or communications personnel like dispatch that might be involved in the incident but not on the scene.
Well, first off, we start with again, it starts with training. We train all of our dispatch personnel as well as our custody personnel, which is actually different. They're not police officers or custody personnel in mental health. And although we only give them 8 hours, it's pretty intensive 8 hours when they first go through their training. And we're in constant communication and contact with them. We respond to the jails. We answer questions all the time. And we're constantly working with them to kind of improve the way we handle things at the custody level and as well as in the dispatch level.
Great, thank you so much. I think we will move along to Detective Casillas. Take it away.
Hello. Thank you guys all for sharing. It's so exciting that so many of us are working towards a mental health and law enforcement collaboration. Many of you guys already covered what we do here at Salt Lake City Police Department, so my focus is going to be on our mental health and substance abuse unit, also known as the Community Connection Center. The Community Connection Center, the mission is to provide a safe environment for people to access individualized care, support, and appropriate community resources. The vision is to become a leading national model and evidence-based practice for partnerships between social work and emergency service entities. The reason that this program was developed, in which we added social workers with law enforcement, was because the community was asking for help for the homeless population who have high rates of substance abuse and mental health issues. Our office is located right down in the downtown area in which the homeless shelter is located. So our unit is comprised of both non-sworn and sworn officers. The non-sworn, they're known as the Community Connection Team, consists of one social worker who's a manager, and they have 3 caseworkers, 1 master level clinician, 2 transportation drivers, and 2 master level interns. We also do assessments in the field, and we do assessments in our Community Connection Center. It has 2 components. There's a walk-in piece, which I'll talk about in a minute, and then we do a field response similar to the other agencies in which we had a law enforcement officer go out with a social worker and do field days. The sworn, there's 2 components. We have a sergeant over the host team. That's the homeless outreach service team. And their main focus is with the homeless population, and there's 2 officers currently assigned there. He is also over the CIT, which is the crisis intervention team, and there's 3 officers focused on different components, including crisis intervention training, officer wellness, and we manage a queue of any calls that come in to service for mentally ill consumers. Our numbers are about 10 to 20 calls per day that we receive for a person who might be suffering with a mental illness or substance abuse. Now the reason this came is because both officers, the community, and service providers had some concerns. So the officers' concerns is they didn't know how to differentiate between mental health and substance abuse, and they still don't know. A lot of times, schizophrenia may look like someone who's used meth. So they wanted to train officers on how to identify those a little better or have someone to contact when they need help doing that. Legislative changes has been making it difficult to place individuals in jail and the drug possession charges have dropped. So certain drug possessions we were able to take to jail, so we take them away from the environment for some time, but now we are not able to do that. And that's pretty much screaming for our community to get more involved and to provide more services, wraparound services for individuals. The jail has lots of restrictions. They won't take misdemeanors. They might only take felonies certain days or a misdemeanor A or above, which really restricts us because a lot of our homeless population and mentally ill consumers, they do have high crime rates but low charges. The hospital has been feeling an effect as well. Because we no longer take to jail, we're taking more people to the hospital. We realized that we needed to communicate better and find a long-term care for these people. Detox was another concern for officers because not everyone wants to go, not everyone can stay, and it doesn't fit everyone's needs. And of course, we have the repeat offenders or the high utilizers in which we need long-term care for. So those were officers' concerns. The service providers, they have a hard time getting people to appointments. As we may know, people who need help may not have a support system, may not have vehicles to drive to and from their appointments, and they just are a lot of times afraid to get help. Another thing is managing medications. As you may know, people have the right to take or not take medication, so follow-up from the providers is very difficult. They don't know how to locate them, to check on them if they're not in one of the provided facilities. Funding is one of the biggest things that is difficult for us to get, but now that we're working with the jail, the hospitals, and the local mental health providers, we're looking more towards funding. Short-term therapeutic interventions, we are actually doing those with our field officers and social workers. We are actually doing therapy in our Community Connection Center and when we go out in the field, but a lot of that is short-term. And that's a concern because short-term only puts a Band-Aid on the problem. And then coordination of care was a huge issue where everyone had ideas, but no one was communicating. So we put this Community Connection Center together so people can start to communicate and get people in the same line of care. So the concerns for the high utilizers or people with mental illness or substance abuse is they fear their safety. They're in a high crime area and they're in a vulnerable state. We have a lot of drug dealers that will go down and sell to vulnerable people, and they don't feel safe in recovery in those locations. And a lot of them have informed us that they're scared of change, because change, as you guys may be aware, is scary. And there's also frustration with the system. It's hard to navigate. Navigating warrants, navigating getting help, what to do with family, how to get there. It can be a lot of work. And then, of course, there's a history of hardship, and it's hard for people to get jobs who have a history or lack of job. So the Community Connection team, this is what they do. They provide intermittent, short-term therapeutic intervention for individuals. They can walk in, set up an appointment with one of our social workers, and they can come weekly until we get them into longer-term care. They also help us, the CIT team, educate officers on other alternatives for individuals who are in a crisis, so that we also have NAMI. We have what they call clubhouses, and we have detox centers. So there's a lot more resources than officers are aware of. And then they also coordinate care between agencies. So we work with our local, it's not just Salt Lake, but we work with like our West Valley, Utah County, so all the surrounding agencies, and we coordinate care because high utilizers walk between the lines. And we want to make sure that we help all of them as much as we can. They help us get access to detox beds, and the Community Connection Center also has computers for individuals to use that they're working with one of the case managers, so that emailing, trying to apply for jobs, trying to get their birth certificates and so forth. In case management, a lot of these individuals need someone to help them through the system, and that's what the Community Connection Center does. They help them through the mental health system, and they're really good resources for the community as a whole, the crisis intervention team, the host team, and they're call responsive with law enforcement. They will go out with both host and CIT detectives. So the homeless outreach team, really quick, they will go out and they focus just on the homeless population, not just at the shelter, but in surrounding areas. They'll help them with employment or contact with employment, help them get IDs. We have a lot of people in Utah that come.
Detective, are you still on the line? All right, it seems that the presenter is having some technical difficulties. Let's pause and see if she's able to call back in a moment.
In the meantime, does anyone have additional questions for the Pinellas County team or the Los Angeles team?
One of the questions that was submitted prior to the webinar could be put to any of our presenters so far, I think, and this was about whether the mental health strategies that you're implementing, what implications they have for safety of officers.
I'm back.
Oh, all right.
Where did you, where were you at?
You can pick up right where you left off.
Okay, sorry about that. So I was talking about the homeless outreach team. We just help with different types of programs to include helping homeless populations with employment, receiving their IDs or birth certificates, transitional housing, receiving bus passes, and reunification passes. So the reunification, we have a lot of people who come from different states, and they don't know how to get back home. But the only way we'll help them get back there is if there's someone who is willing to take them and help them. So we just won't send them anywhere. So that's what our homeless outreach team does. So how do we fit into the Salt Lake City Police Department mission? Well, the Community Connection Center, as you guys are aware, they are social workers who are liaisons between law enforcement, between the individuals who are experiencing homelessness or who are in a crisis, and the community service providers. So they go to committee meetings, they go out with us in the field, and they help us bring everything together. Again, HOST works closely with psych officers, and they do a lot of outreaches in the city for the homeless population or anyone who might become homeless. CIT, we conduct crisis intervention training. We do the 40-hour training. We do a 2-day CIT negotiations training. We do dispatch training. We also do a CIT for youth, a PTSD training, and officer wellness training. So both HOST CIT teams, we all meet up with social workers and go out into the field once a week. We're all under the same roof, and we're located right downtown for easy access for persons with mental illness and substance abuse. Something that we're doing, as I mentioned before, is we'll go out in the field with social workers once a week. We share data with the jails, the hospitals. We have a community meeting where we meet with hospitals, all the providers, the jails, so that we can get these individuals on the same line of care. Our total employees, like I said earlier, about 20. We have 6 officers. The transportation drivers, if we have someone that walks into the center and they are ready to go into treatment, they can transport them to the treatment center. If they need to go to detox, they'll transport them to detox. If they need to go to the hospital, they'll transport them there. So to try to drive down costs. So I just want to talk a little bit about the outcomes up to this point. Our center, even though we've been doing CIT for 14 years, we did develop this overall center in August of 2016 till this year. So far, we've had 1,093 contacts who walked into our center. Of those, 27% needed transportation, 21% came in for housing, 14% was for treatment, 5% for employment, 4% for documentation, and 29% for miscellaneous needs. We decided to do what we call Operation Diversion. We like to divert people from the jails into treatment. We did a 3-day operation in which 60 people were assessed for treatment. 48 of those were requested to go to treatment, 10 declined and decided to go to jail. 2 went to the emergency room. So of the 48 who decided to go to treatment, 1 went to jail, 1 was removed from treatment because it wasn't appropriate. 5 absconded from treatment, and 41 are currently engaged in treatment. That leaves us with an 85% success rate in the last several months. So we're really excited about the numbers and the outcome and the data that we're collecting. This last page is just any contact information for the people in our Community Connection Center. That's all I have for right now. Are there any questions?
Thank you so much, Detective. Zoe, any questions that have come in specifically for Salt Lake City? Otherwise, we could maybe revisit the question you posed just a few minutes ago.
No specific questions for Salt Lake City right now, though everyone listening should certainly feel free to send them in via the chat feature. So maybe we could reiterate the question that was sent in prior to the webinar about how these mental health programs have implications for law enforcement officer safety, and open it to any of our panelists.
This is Lieutenant Bixler from the Los Angeles Police Department. I can start with that a little bit. Our programs, because we're, when we get them on the front end through triage, one of the benefits is when there is a barricaded situation, jumper, any of those high risk situations, we can automatically, by calling our triage desk, we can print out these reports, get them out to the incident commander, give them a much better idea of who and what they're dealing with. And that leads to less force being used, better outcomes, much better understanding, and that leads to greater officer safety. The other piece is when people have escalating behavior, by funneling them to our camp unit and by working with them to get that permanent linkage, that long-term linkage, that person is no longer prone to being out there in a dangerous situation where they're decompensating, having a greater likelihood of having an encounter with a police officer, who may just be responding to a call. So in those types of things, we really think it's making a big difference with officer safety. The other thing is just by our training, we're teaching a heavy emphasis on de-escalation, on time, space, and background information, and allowing that officer to have some more tools at their disposal to de-escalate that situation, because we know when police officers get into a fight, it's not pretty, and most likely somebody, including police officers, are getting hurt. So we really try and emphasize those. And that's just some of the ways we out here see that. Anything else, Detective Dempsey, on that? Okay, I'll mute now.
All right, great. Any other comments from other panelists on that question? Okay, great. We will wrap up then. This is Laura Kunard again, and I wanted to thank everyone for participating on the webinar today. We appreciate your time and effort and your attention to these important topics. Dr. Coldren, did you have any concluding remarks you wanted to share?
Just maybe a word or two. I want to express on behalf of BJA and Kate McNamee, who could not be with us today in this webinar, our thanks to all of our presenters and to the people who attended this webinar. We very much appreciate it. For those of you who might be new to this or to the Smart Policing Initiative webinars, I just encourage you to take a visit to the Smart Policing website. It's very easy to find, and you'll find information about all of our Smart Policing sites up there. And just a reminder for everybody to please pay attention to the evaluation when it comes your way after we sign off. As I said earlier, I'm very proud of the information that was presented here and the work that all of you are doing on behalf of people with mental illness in our community. So I thank you all very much.
All right, thank you everyone for participating, and we appreciate your attention this afternoon. Have a good rest of your day.